Good Friday morning, everyone. I'm Dr. David Wild, Vice President of Performance Improvement here at the University of Kansas Health System, coming to you live from the Dolph Simons Jr. Family Broadcast Studio. With me today here in the studio is Tim Williamson, our Vice President of Quality and Safety, and of course, Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control. Good morning, gentlemen.
Good morning.
We're going to spend a lot of time on your vaccine questions in just a moment. But first, Dana, how did we do overnight?
Not good. So, we understand, and we've seen the past couple days that the total number of cases in the Kansas City metro area, after taking a dip and reaching a slight nadir, has kind of increased now again. So back on an upward trend. In the hospital, we are seeing that upward trend as well. But I think, again, this is the trend from that continued rise in cases from 10 or 14 days ago. So 101 patients in the hospital right now with active COVID-19. 45 of those are in the ICU and 27 of those are on the vent. We still have 66 patients in that recovery period out of that acute infection phase, and 8 of those are on the ventilator. And then in Hayes, their numbers are about stable from where they were yesterday. A total of 32 patients in the hospital, 29 of those are active as well. So, unfortunately, we are seeing our active number of patients going up.
So 167, I think, total COVID patients this morning who wouldn't be in the hospital otherwise if it weren't for COVID disease. And that's not an insignificant percentage of our actual beds for medical surgical care. We'll talk a lot about what we're seeing and what we anticipate here in just a minute. But before we do that, any reporter questions on the line today?
Yeah, good morning. Good morning, Cody Holyoke with Channel 9. I know you guys are going to be talking about preparation, so I won't touch that as much as I'll ask a little bit later on your timeline, and you'll probably get to that. But just your overall sense of, just as people, what are your hopes right now? How are you feeling as we're kind of on the cusp of this essential scientific breakthrough, this monumental occasion?
Yeah, I'll start. I'm sure we all three have something to say about that. I think you're right. There is a lot going on right now. The pace of all of these things that we've seen, right? Not just development of 2 vaccine candidates that really look to be strong and I think are on the fast track for emergency use authorization probably within a day or 2 for the Pfizer vaccine and then not long for the Moderna. We've all talked about how fast that's happened, how fast candidates have been developed and how fast the phase 3 trials have been completed and how fast even the data analysis has happened and the interim checks have supported what we see in sort of the final data. So it really is sort of a monumental sort of achievement. It's interesting, it comes kind of at the same time as we heard about the Sanofi or the GlaxoSmithKline and Sanofi candidate not generating enough immune response in the elderly. They publicly said, I think last night or early this morning, that they were actually going to go back to the drawing board and that there would be a delay then in their candidate reaching the market or even applying for emergency use authorization. And that was part of the Operation Warp Speed plan. In fact, we had pre-purchased the United States has as a country a number of doses from that candidate. So lots going on. I think all in all, very, very positive news. We've talked, I think, a lot about light at the end of the tunnel, but a long tunnel, and we've got some work to do. And I don't know, Dana, things to add?
Yeah, initially wasn't too optimistic and was skeptical, but as we saw the first media reports of what the companies had reported their efficacy was, I got more optimistic, certainly after reading the FDA brief from Pfizer and reviewing all those phase 1 data and then the phase 2-3 data, especially on the safety stuff. We know it's important for people and we have to understand that it's important to be transparent about the safety, but also looking at the immune reactions and the immunogenicity of the vaccine, I've become a lot more optimistic. So hopefully these 2 mRNA vaccines, the one that we've heard the most about, the Pfizer and the Moderna, will both be similar efficacy and be very strong for creating immunity and durable immunity as well.
So for those of you watching, Dr. Williamson has been leading sort of our planning around vaccine administration, our plan, what distribution looks like, how we set up clinics, working with our teams here to do those things. I think I heard you say yesterday, while your primary role is not as a vaccine physician, you can talk about this at length now. Thoughts you have about the general picture of where we're at?
Yeah, hopeful, and it's been so much fun because there's just a great team working on this here, and wouldn't even try to list all of them because there's so many, but they're just so wonderful, but hopeful. And I had that same feeling reading through the FDA briefs that Dana did of excitement. I never thought I would say I was excited to read an FDA briefing paper, but this is going to be a game changer. And so that was really hopeful, really exciting. But we're going to come back to this several times. It doesn't mean that we can now let our guard down. There's still a lot of work to do. So this is historic in a good way. We've had so many, we've used the word unprecedented in a bad way so often, but I think for one of the first times we can say unprecedented in a good way, and that's great.
Very true. So Cody, we will talk, I think, much more about timeline and other specifics as we answer some of our other questions. Any other reporter questions on the line? All right. We'll jump into community questions that we've gathered around the vaccine over the past several days here in just a minute, but I want to take some time and come back to that conversation before we do about what's happening here, what's happening at the national level, and what we anticipate. As Dana said, we're really dealing with hospitalizations due to infections that were transmitted 10 or 14 days ago right now. And this is, by now, probably familiar for those of you who are able to join us regularly, but this is the national look. This was yesterday's look, so data through Wednesday. The left-hand side is the number of tests per day that are being done. The sort of red, second from the left, is the daily number of new cases, with the solid line in each of these cases being the 7-day rolling average. The blue is the number of people in the hospital currently. And then the far right, the gray and black line, are daily deaths. And there was a lot of conversation about topping 3,000 daily deaths Wednesday. That's definitely part of the story of what we're seeing and feeling right now. But I want you to pay attention in each of these curves to sort of the 7-day rolling average line and the drop that you see around Thanksgiving in each of these, in number of tests, in number of new cases reported, even in number of deaths reported. That happened right around the Thanksgiving holiday. And I say that very purposefully. This was likely not due to a decrease in any of those things other than maybe tests happening. We know that there were less tests around the holiday, but instead sort of a reporting phenomenon. And so just less resources around as public health offices and government offices gave their teams a little bit of a break to be with their family, sort of that dip related to reporting, and now sort of seeing that the curve hasn't changed. The slope of those lines is no different now than it was before Thanksgiving. And we really have yet to enter the point where we would expect to see the peak impact from Thanksgiving. We know 2 or 3 weeks minimum after a change in behavior, including gathering for a holiday as a change in behavior, before we really start to ramp up in number of new cases, and that peak really being 3 or 4 weeks. We've seen that every time with back to school, with mask orders, with reopening phases across the past several months. So we really anticipate the big push from Thanksgiving in the sense of new cases to start right now and probably continue over the next week or so. And that's important because hospitalizations have always and will, I think, for the foreseeable future, continue to follow new cases. And so we anticipate the peak in new hospitalizations from Thanksgiving-related activities to be 2 weeks or maybe even 3 weeks out now, although we'll begin to see the impact, I think, pretty quickly here in the next few days. The next slide looks at states that are here in our region, and I gather this group very specifically because these are the states that are frequently calling us for transfers. And Tim's looking at me because he's on transfer call this week. It's not me, which means that he got less sleep than I did last night. I actually got more than 5 hours straight without a phone call, which was nice.
I did not.
Yes, I am sure. I point this out, though, because look at Kansas, the far right, on number of new cases. The number of new cases per day, population adjusted, is higher than Oklahoma, Missouri, or Texas. And all of these states have had a rapid increase and have seen that rebound, if you will, from Thanksgiving reporting. The blue numbers on the right-hand side, again, population adjusted hospitalizations. We'll continue to see those numbers increase as long as new cases are increasing. So definitely concern for hospital capacity. It hasn't changed any. The next slide is the look here at the metropolitan area. As Dana mentioned, we saw the dip that you've seen at the national level and the state level here in the Kansas City metro as well. And we've seen the rebound to a rolling average being at or over 1,100, I think, if we include yesterday's results. So the pattern that we were worried about definitely continues, and we would expect that it is still several weeks before we see relief from the hospital capacity concerns that we've been talking about. And remember, we keep saying this, but this is a problem that's very fast to develop, right? Hospitalizations increase rapidly, and then people are in the hospital for days, sometimes only 3 or 4, but most often 7 or 8, and sometimes as many as 30 if they're in the ICU. And so it trails off very slowly. So that's really the background, I think, that's explaining what Dana said, what we're seeing in our hospital, our increase in numbers. We actually know from talking to other health systems across the metropolitan area, we do almost daily, that the increase that we saw yesterday had happened in other metropolitan hospitals over the past several days as well. So not unique to us. So that's the background. That's what I brought. I don't know if Dana or Tim, anything for context with that before we get into vaccine questions?
Not really. I mean, I can tell you yesterday we had calls from all 4 of those states, and as we do nearly every day. So there are very real stories and people behind those numbers, and I think sometimes the people can get lost behind the numbers, and
Very true.
each of those numbers, and we're going to get to that at the end, but each of those numbers represents an individual person. So
Dana, anything to add?
No, nothing to add.
All right, question time.
All right, first questions. When do we expect the first vaccines to arrive in Kansas?
Well, Tim, you're the closest to this. I'll let you start.
Yeah, and we are in frequent conversation with the state and paying attention to the national news, and that is a bit of a moving target. Our latest information is that probably will not be before Monday, and may be as late as Wednesday. So I'm gonna give a window and say between Monday and Wednesday, and we'll be prepared when it does.
When will our employees and physicians be required to get the vaccine?
Well, the short answer is we're not going to require our employees or physicians to get the vaccine. We're not going to mandate it. We do, as most metro area hospitals, mandate the influenza vaccine, but that has been FDA approved for a very long time. This vaccine will be under emergency use authorization. We're going to highly encourage it, but we're not going to require it.
And I'll piggyback just a little there. You know, when Tim mentioned that this vaccine will be used and administered for the next several months under an emergency use authorization, what that actually means is that the full data set and the normal approval process for a drug or a vaccine in this case has not been completed. And we know that going into it. With that will come some new data. It's very likely, maybe even probable, that we will see differences in effectiveness numbers as we get into a broader population and a larger population, and that's okay. That doesn't mean anything's bad or wrong. It just means that we're seeing in a larger population what the total impact of each vaccine candidate will be. It's also important, I think, to notice or to note in that conversation that things that are administered under an emergency use authorization are still considered experimental because the trials are ongoing. And so don't be scared by that if you hear someone say, this is an experimental vaccine. It is simply based on the fact that we don't have the full standard approval. And I think that's an important conversation as we get into how many people need to be vaccinated. It's also part of the reason we don't require it.
Yeah.
I think we'll be very transparent about that for our physicians, our healthcare workers, everywhere across our organization.
And it's really saying there's such a great need for this, and there are not alternatives that are better, and we have enough data that it's safe and it's effective, that we're going to use it while we're still continuing to gather the rest of the information that we need.
Cost. I believe at first there won't be a cost.
Oh,
The
sorry.
cost.
That's
Next
on the next question. When will your patients and the general public be able to receive the vaccine, and will there be a cost?
So, harder question to answer, I think. It's dependent on so many factors, at least the timeline. I think patients with chronic disease.
I can take the second part. You take the first part.
Yeah, thanks. So patients with chronic disease or patients that live in nursing homes, general public in the nursing home or long-term care facility population, will come before the general population of people who don't have chronic disease or need to reside in a long-term care facility. My guess is, and this is totally a guess because it's dependent on how long it takes to get through all of the essential workers and healthcare workers and those that live in long-term care facilities. It also depends on logistics of manufacturing and distribution. I think it's probably safe to say no sooner than the springtime for the general public and probably the summer.
Yeah, I think that's fair. And when you look at CDC and KDHE's recommendations for who gets vaccinated first, phase 1A is healthcare workers and long-term care residents and staff. And so long-term care residents and staff actually probably will start getting the vaccine within the next couple of weeks. And that's through a partnership through Walgreens and CVS with these same vaccines with Pfizer and likely ultimately Moderna. Then after that, essential workers, people with high-risk patients, but that probably late winter, early spring, and then on through the summer. And I think Dr. Fauci has said really getting everybody by earliest of fall of 2021. But there's so many unknowns, and the biggest unknown is just the cadence of how we'll get the vaccine. How's your crystal ball, Dana?
Yeah, I think that's an important point to make because it's going to also matter on how much supply we have. Hopefully everything will go well and the companies will continue to make their supply. There won't be problems with production. This is one of the nice things about Operation Warp Speed. As Dr. Wild had mentioned, the United States, the government did buy some from GlaxoSmithKline, anticipating that they would have a safe and efficacious vaccine to use initially, because we need all of those companies to produce most of that stock so that we can roll those vaccines out, because just one company is unable to do it. And even Dr. Fauci said, the biggest thing we would lose is money if this doesn't work. But more companies, that was part of the collaboration with Operation Warp Speed, more companies to have more production to get those stores, those supplies ramped up so we can get those vaccines out to the mass population.
So that's going to impact the timeline too. When do these other vaccines come on board and the rate and the volume that they can produce?
Both their authorization, emergency use or otherwise, and then the manufacturing. And as far as the cost goes, Operation Warp Speed or the federal government did purchase or procure the actual vaccines. So there's no cost for the vaccine. But there may be a cost for the administration in certain circumstances. So I don't want to say there's no cost or there would be no cost in any case. You may have a fee just associated with the sort of resources necessary to administer the vaccine if it's not delivered, say, by a public health office or a large vaccine clinic, for example.
Yeah, and that'll be able to be built insurance and other usual routes. But what we've also been told and very much support is that no one would not be able to get that vaccine because of the inability to pay the administration fee. So we don't want anyone to think that modest administration fee would get in the way of them being able to be vaccinated when it's available.
Okay, how do we really know if the COVID-19 vaccines are safe? And some people are bothered today on the thread about the no liability clause that the manufacturers apparently have, and that makes them nervous.
So let's start with the how do we know it's safe, because I think that is a different conversation than a no liability clause or any of the sort of emergency or disaster relief measures that were taken for drug manufacturers or other industry as well. So safety. I know all three of us, I am sure, have read, and I am not joking, the Pfizer 50 some odd pages, as Tim shows his prop, of data released about both safety and efficacy. And you heard Dana and Tim both say that they were somewhat skeptical at the beginning when we saw early results, and I will admit I was probably leading those conversations at times based on the
Someone
data.
like you.
Yeah, I know, based on the data that we had available. But now I think I'm going to speak for everyone, and then they can tell you their specifics. I think we all three would agree that the safety profile as described in the Pfizer data for the 44,000 people that were included in this data analysis does show, I think, that we don't have any concerns about safety. So, Dana, I'll start with you. I think you've read it 3 times if I
tried to
remember
read
right.
the bigger 90-some page one as well, because there were 2. But, I think we were extremely lucky to have this week and have the guests on that we had. Dr. Polland, obviously, from the Mayo Clinic, who was totally in favor of this and stating how safe it was. Dr. Catherine Satterwhite, who works for HHS, who said, so we all get that data, the FDA gets that data, we are able to read that, but those independent scientists that are analyzing the data, they get that raw data, so they are able to analyze just the numbers themselves. It hasn't been manipulated or analyzed by the company itself, so they are looking at the raw numbers, and so that is one more safeguard for these scientists who have no conflicts of interest in any of these vaccines. They are purely looking for safety. Those are all safeguards to take to understand whether, first of all, can you get that information, which you're able to get that information and review it, but then you say, well, how do I know that's not manipulated? Well, we have those other safeguards, the independent FDA reviewers who have reviewed all the raw data, all the raw numbers, looking at everything, and still going ahead and saying, we recommend that this does get approval. So I think there are steps there individually, but also on the broader, larger picture of the group that is actually going to be looking out for us, the people, the citizens of the United States, in actually recommending approval.
Yeah, I think Dana's point's crucial, and we've all looked at it, but there, a lot of people, much smarter than I am, have had their eyes on much more granular data.
Yep.
I don't know, I can't remember hardly anything else that's had as much transparency around the data.
Yeah.
And for those of you who are interested, the FDA briefings are out there in the web. The New England Journal has an open access article with the peer-reviewed data. But at the end of the day, I think my marker is would I take it? And before someone asks, the short answer is yes. I would take this based on what we know and or recommend a family member to take it. So we believe it's safe.
And I'll try briefly to address the kind of question about liability concerns. So early on in the pandemic, both federal and state emergency declarations provided liability relief for a number of different circumstances. One, at the federal level, was some relief or some liability relief for drug manufacturers as they developed novel treatments for a brand new disease that we knew nothing about in record time. We already talked about how monumental the task of developing not 1 but 2 vaccine candidates in such a short period of time, and there are others, of course, that are coming down the pipeline, but 2 that appear ready to be authorized for emergency use. Those things wouldn't have happened without that liability relief. Or protection that says, in general, there's some control around what liability concerns would do to driving a timeline. That doesn't mean, though, that these are unsafe, as we just talked about. The safety profiles and those things that are reviewed by independent monitoring boards, at least based on the data that we have from the 44,000 patients so far, I think should alleviate any concerns that things are being rushed or pushed out that are unsafe, because the safety review is independent of the liability concerns. So hope that helps. Joe?
Yeah, thank you. Do we know how long it takes the vaccine, once given, to be effective against COVID-19, and how long that protection will last? And I'm going to tag on with Chris. He just wrote in, too, kind of on this theme. Would you expect the results in the general public to mirror what the drug manufacturers are getting? Unpack that.
Yeah, okay, so at the top, how long after vaccine administration does it take to be effective?
So I think from what we saw, it's about, and Dana can correct me if I'm wrong, but I think it's about a month to start seeing, some immunity after that first dose. You do get some potential immunity after the first dose, but it's not as impactful as what you get after the second dose. So to get your second dose, and then, so you're looking at probably a couple of months. I'll also just tackle real quick the across the general population. So they did do subgroup analyses looking at across race and age and gender and different comorbidities. And really, with the exception of folks who were over the age of 55, had a little less side effects from the vaccines. There really was no difference in any of those subgroups. So I think that gives us some initial hope and promise that there won't be big differences. And of course, one of the things we worry about the most is the older population. Will they have the same immune response and be able to protect themselves with the vaccine? Based on the data we have, and it's initial, it appears that there's no huge differences between any subgroups.
Yeah, I think that's right for most vaccines, especially for like things like influenza vaccine. We say, if you're traveling and it's early in the season, you maybe want to get your influenza vaccine 2 weeks before you're traveling, because that gives your body time to build up that immunity. What Dr. Williamson was talking about was especially what we had heard before. Really, after that second dose is when we see most of that immunity happening. So what happens is you get that injection into your muscle, into your deltoid, and that starts these immune complexes and these immune cascades going. And that is the cells taking up what we're giving in the vaccine, and then your cells starting to produce that spike protein, and then presenting that spike protein to the other immune cells. And that starts off a cascade of creating those B cells to create antibodies, and then the T cells to create immunity as well. You have some good coverage after that first vaccine, but it's definitely not as good as that second vaccine. And so after that second vaccine, whether for the Moderna or Pfizer, which are 28 and 21 days after that first dose, you're really looking probably about 2 weeks from that to probably have the maximal immunity. Certainly in that time frame, you will have some amount of immunity, but I don't believe that was really necessarily studied as far as protection against infection and disease itself. They do have some data points there, but we're really looking at that, probably that 2 week from that second dose is when you're going to have your maximal protection. How long will it last? I don't think we know that. There was a question, certainly it's probably going to last longer if you get both of those doses rather than if you just get that one dose. That is going to be some of the other things that Dr. Wild had talked about, the ongoing studies and looking at those types of information and data. How long is that immunity going to last? How durable is that? I don't think we know yet, but hopefully we'll get some of that information.
And I think it's reasonable to expect this will be at least a seasonal vaccine like the flu shot. We don't know, but one can imagine that it won't be one and done forever.
Right. We only have data really, for maybe two and a half or 3 months from the second dose for even those that were early volunteers to participate in the trials. So we just don't have any information on durability. And I'll make an attempt to translate. Even the anesthesiologist in the room needs to translate what Dana just said. Basically, you get a vaccine, right? The shot is given to you in your arm, and then your body has to respond and then becomes its own little sort of manufacturing plant to generate everything you need for immunity. So I still get T cells and B cells confused, and I'm sure maybe someone else out there does as well.
Thanks for translating for the lung doc, because I was wondering,
I
what he
thought
just
that was
said.
in lay terms. I tried to understand for those of you out there, those budding immunologists, there are T cells and B cells. Just in general, think B cells about antibodies.
And for the rest of us, we have bodies that are making our own little factory. Okay. So these early vaccines require 2 shots. What happens at the second dose on that due date that I don't do it, or I'm late, or I skip it all together?
Dana?
Okay.
I mean, I think Tim can probably speak to that a lot better than I can. One of my major concerns is that there won't be the second doses there, but as we heard, again, Dr. Catherine Satterwhite talk about, the government is holding back those second doses of what they have already. So those that can get the second dose will be able to get the second dose. We don't know and maybe you do, we don't know if there is a grace period in that time. What if it's for 2 or 3 or 4 days late? We don't want it to do that, but I'm not sure if there's a lot of information about that.
There's not. All I can say is in the study, the window was 19 to 49 days that they allowed. So 21 days is the target. But the reality is getting exactly 21 days is not going to happen. We know from other vaccines the challenges of multi-dose regimens and getting that second dose in and not forgetting or moving or being on vacation or whatnot. So there's some window, but we don't know exactly what that window is.
So now I'm going to translate for the lung doctor. It is better to come and get your second dose a few days late or a few days early. We would much prefer you do that than say, oh man, I missed my 21 days, I'm not going to get the second dose.
Yep.
So if there's a question about what does that mean to each of you, right, don't worry so much about the specific date, get the second dose. It's extremely important and beneficial in the process.
Thanks for translating.
We are so lucky to have you this morning, Dr.
We
Weil.
will
Thank
translate over here.
Besides storage requirements, what are the differences in the vaccines and which one is best?
Well, Tim.
Yeah, so, this is a great question and one of the most common questions, but we've not seen all the data to the same degree we have for Moderna that we have for Pfizer. From the preliminary reports, we think that they're going to be very equivalent. There's not going to be remarkable differences. There are differences in how they're stored and how you transport them and that sort of stuff. So I think for most of us, our recommendation when it comes to those two vaccines is going to be, we think they're going to be roughly equivalent. We'll review the data to make sure that's the case. And the best vaccine is going to be the available vaccine. And so that they may not be, I think whichever one is available to you at the time it is available is the best one for you. As these other vaccines come on the market and get in, then we'll have to evaluate, does that change our thinking any? I don't know if it will.
Yeah, I would totally agree with that. I think today on December 11th, the best vaccine is Pfizer vaccine, only because we have that data that we can review. Once the Moderna comes out, we want to review that FDA briefing and any other data behind that. And then, of course, with AstraZeneca, all of that as well. So I think, just as you said, which one is available and what data do we have to review? And again, remember, there are several different types of vaccines for different infections that they have multiple companies producing vaccines. So just multiple companies producing vaccines for a coronavirus vaccine or COVID-19 is not unusual because there are other infections which multiple companies produce vaccines for.
And I'll maybe take the long run answer to that. So as we have more and more data about each of these vaccine candidates, it's very, very possible, and I actually even hope likely, that we end up with a menu of vaccine choices, understanding that they may be slightly different. Some may work better in an older population, and some may provide better coverage for healthcare workers for a different reason. And that in the long run, that menu allows us to say the best vaccine is the one that is most appropriate for you. And so that truly is something that is, I think, very unique about what we're watching unfold in real time here.
I agree.
All right, I've heard you say the risk associated with the vaccine is lower than the risk associated with getting COVID-19. Doesn't that depend on the health of the person?
Well, I'll take this from a population health perspective first, and then we could talk about individual risks maybe. So remember that one of the big benefits of a nationwide, right, a population, entire population vaccine program and push is that not only does getting vaccinated protect you, but it protects those that you come in contact with. Sort of that goal of herd immunity, if you will, except through a vaccine and not through everyone in the community actually ending up testing positive or having the disease. So while there may be some people that are at very, very low risk individually of significant or severe disease, the overall picture is that we are doing this to protect our community, the entire population. And so it's not always just an individual risk versus benefit conversation. There are other factors to consider.
Yeah, and I would say if you're concerned about getting the vaccine because you think it'll give you the disease, these vaccines, Moderna and Pfizer, will absolutely not give you COVID-19. There is no way they can give that. Again, all they're doing is giving you a piece of the genetic material of the virus so that your body your body factories, your cells can create that spike protein to present it to your immune system to show that this is a foreign pathogen. We need to create an immune response to it. So that risk there, and then knowing what we do about the safety, where a large proportion of people will get some mild site reaction or discomfort, meaning that it will ache, but they won't even have to take medicine for the pain, and it won't affect their daily life. So there is in no way a higher risk of probable or possible bad outcomes taking the vaccine compared to getting COVID-19. You absolutely do not want to get COVID-19.
The only thing I'd piggyback real fast on top of that is we say low risk, but that's not no risk. And we've seen college-age patients with in the ICU with horrible heart failure, and we know that even children can develop neurologic problems following this disease, and so we talk about low risk as meaning I can't get the disease or I won't be that sick from it, but that you can't predict that, and so don't want to lose sight of that.
Yeah, the pediatric specific issue is interesting. So we heard from Children's Mercy, I think on an ICU call this week, that the multi-system inflammatory syndrome in children, the really, really sort of high ramp up of the immune system weeks after being infected in kids has increased. The number of cases and their concern has increased over the past couple of weeks as there are more and more infections in children. So again, while you may be considered low risk, we can't tell who's going to have those sorts of problems.
And because I suspect somebody will have the question, this study included patients down to the age of 16, and I think the emergency use authorization will be 16 and above. They're expanding the Pfizer trial to 12 and above. So trials in children typically follow those in adults, so there'll be a little delay in terms of knowing safety and efficacy in kids.
We have two more community questions, but before we go there, we have two reporters who have joined on the line, and they have some follow-up questions. We'll go to Lindsay Shively with KSHB first.
Hey, good morning. I heard you talking about the window with the Pfizer vaccine. Wondering about the second dose. How crucial is it to get it immediately? Would it be better, or why not, double the amount of people who could at least get a first dose and at least get that much protection versus holding back those second doses to ensure they get those, and instead of getting as many second doses made as they could and getting a lot more people that first dose?
Yeah, great question, Lindsay, and one that we have all talked about, one that the Advisory Committee for Immunization Practices has talked about at length. I think Tim probably has a pre-prepared answer here.
Well, no, it is a great question. And so the short answer is we don't know what happens when you do it in that way. We know what happens when you do it with a dose and a booster dose 21 days later. We know that you get some immunity after that, but it's not 95%. It may be 60 to 80% immunity after the first dose, but we also don't know how long that lasts. And so, it's a great question. Can you make that available supply last longer? But the short answer is we don't know that it would have the same impact. And so right now, the focus is on doing what we have the most information or the most data that is the most impactful.
I would agree. I think we are going based on what we have the data about. It's not only those phase 2 trials, it's that initial phase 1 trial that showed that you had a boost in your mean antibody titers, your high antibody levels of neutralizing antibodies, and your T cell responses really are boosted in a lot better after that second dose. So it's based on what we have the information, not what but what the FDA and Pfizer has the information to present.
I want you to know I didn't say neutralizing antibodies in my response.
And if I think about the population health sort of perspective on that same question, if you think about a single dose providing, let's say 60% efficacy compared to 80 or 90 or more with the studied regimen of the booster at or around 21 days. If, say, we are at a 60% efficacy by only giving one dose, and we still are only getting to 20 or 30 or 40%, or even half, right, 50% of the population, 60% of 50% is not very beneficial in generating the response we need in the long run. So it is a hard question because there are good reasons to consider both sides, and right now I think the answer of We just don't have any evidence to suggest that it is right or beneficial to do a single dose is the bottom line answer.
I think to highlight the two biggest key factors in the long-term impact of this on population health is how many people you reach and how effective is the people you reach. And so if you impact either of those things, your chance of controlling this goes down.
All right,
Right.
one more
Yeah,
reporter.
but Lindsay, do you have a follow-up, or are you good?
No, I'm good. Thank you.
All right, let's go to Shannon O'Brien with Fox 4. Shannon?
Hey, good morning, guys. I just have a question I wanted to get clarification on something that was just said, because I was under the impression from call several, maybe even a month or two ago, that there was not information yet whether or not the Pfizer vaccine would prevent you from spreading the disease to other people, whether or not when you get the vaccine, that just prevents your body from getting sick from it, but you could still spread it, or if it prevents it from even, kind of getting into your body. Am I making sense with that?
Yeah. Great question as well. I think that the easiest way to answer that, and then maybe someone will have to translate for me here. The easiest way to answer that is that to date, those that have received the vaccine have not had frequent PCR testing, right, to determine if they are carriers or could transmit the disease. So we do not know the answer to that question yet. What we know is that the primary endpoints of symptomatic or severe disease or hospitalization have shown lots of benefit. And as time goes on, we will have the answer to the question that you posed. We would expect, though, from our experience with other vaccines and other diseases, that if you don't have severe disease or symptomatic disease, that your ability, even if you were infectious, let's say, that your ability to transmit would be lower and shorter, potentially, than if you weren't. So we believe that there will be significant benefit on that front. We just don't have the evidence to prove it yet.
But the really, really important part of that is, I think there is a misconception out there that you get your two vaccines, you're done. You can run around without your mask. I can run up and stand next to Dr. Wild, but there is still some possibility you could have a mild form of the disease and transmit it. So it's going to be crucial over the next year or whatever time frame that is, that everyone is still wearing their masks, staying socially distanced, washing their hands, and not being in crowds, and particularly indoors. So this is a game changer, but we can't quickly stop our behaviors. And if you walk away with nothing else, I think that is one of the key points.
Absolutely.
We can't let our guard down in the short term because of the long-term promise.
All right, Shannon, any follow-up?
I've got a question on another topic. When you all get the vaccine, a portion of it, I understand, a percentage is going to be kept there at the hospital for your use, and then a percentage of it is going to be sent out to other facilities. So how does that distribution work?
Yeah, at a very high level, at least in the state of Kansas, which is what I'm most familiar with, KDHE in the state of Kansas are managing the allocation of those vaccines, and so they are helping decide where those vaccines go and help with the logistics of actually transporting those vaccines, as well as then starting to work with the local health departments to figure out how outside of hospitals do the vaccines get distributed. So would refer you mostly back to the KDHE and the equivalent on the Missouri side, but they're the ones who are helping decide who gets the vaccine and then make that happen.
Thanks, Shannon. All right, and now we have a question from Amy Anderson with KCTV5. It's prompted by a nurse who's lost a lot of patients to COVID, and it has to do with how you shed the virus, because these patients are dying alone, and it's heartbreaking for the nurse. And so Amy wants to know from you physicians, how long are we shedding the virus when you're in that situation and you're in the hospital and you're sick? Can you speak to that?
How about it, Dana?
Yeah, I mean, I think the best evidence that we have, and again, this is freely available evidence on the CDC on their coronavirus site. We really believe for most people with mild to moderate infection, those who even come to the hospital, and especially those who don't need to seek medical care, you're probably most infectious 1 to 2 days prior to symptoms to 1 to 2 days after symptoms start, and then it goes down from there. So by the time you get to 8, 9, 10 days out, you probably are not shedding the virus in any high amount or level, or have even possibly don't even have replication competent virus, meaning infectious virus at that time, because your immune system has worked and has been able to decrease the amount of viral replication. So that's why there is that recommendation of being isolated for 10 days from your symptom onset. After that 10 days, you really are considered non-infectious. The same thing happens in the hospital unless you have a certain level of illness. And in that case, sometimes if you have severe or critical illness, we would say you probably need to stay in isolation for 20 days. Again, this is all based on very small amounts of literature and the fact that they can actually culture infectious virus in some studies, small studies, that far out. But for the general public, it typically means 10 days from when your symptom onset. If you have other immunosuppression, such as cancer or HIV/AIDS, or other immunosuppressive drugs that you're on, you may be able to have infectious virus even longer, but those are certainly special populations and would just want you to talk to your provider at that point in time.
All right, Wayne with the radio station Parsons has one quick question, and then we have 2 community questions, and then we will wrap up, okay?
All right.
Wayne wants to know, what is the average patient admit at our hospital, and what is the average death currently?
Age?
Age. What is the average age of the patient? Do you know off the top of your head?
Yeah, so it remains right around 57 years old since the beginning, since March to now, for the entire population of 1,550 or so some odd patients admitted here to this hospital. That's the average age of admission. It has varied from week to week, if you will, or maybe if we look at maybe month to month, there was a period, maybe late summer and early fall through early September, where we actually had a much lower age. The average age was down in the upper 40s, even of those hitting the hospital, which I think was sort of a sign that we were seeing more younger people infected in the community, which drove down the average age of those needing to be hospitalized. We've actually seen that number increase again, closer to maybe 53 over the past month or two. So we're seeing more critically ill patients in our hospital and more slightly older, which I think is also a marker of what we're seeing happen in the community. More and more long-term care facility clusters again, which means more elderly people, which means more elderly people in the hospital. So that's maybe a long-winded answer to the question of what does the age look like for those that are admitted to the hospital. The question around deaths, actually the answer there is very, very, very similar to those needing to be hospitalized. So it's not 70 or 80 years old that's the average age of deaths. It's very close to the average age of those being in the hospital.
And the long-term care clusters are why it's so important that that program is starting up here within a couple of weeks of getting the vaccinations out into the long-term care facilities and staff.
Yeah. So when I look sort of daily at the sort of demographics of death and admit patients, I mean, we've had total, not quite 20, but maybe close to 20 deaths that were under 45. So it's not like this is only 70 or 80-year-olds dying. I think that tells the picture, or paints the picture, tells a story. Hopefully answers the question you're asking, Wayne.
All right, thank you. How many people must take the vaccine in order to slow or stop the spread of the virus? Is SARS-CoV-2 with us forever?
Mm-hmm. So there's a big population health question buried in there. It's really the question, how many people need to be vaccinated to develop the herd immunity that says we can change how we're behaving with non-pharmaceutical interventions? Or when I say those words, I mean, how long are we physically distancing and how long are we wearing masks? At minimum, it's 70%. Mm-hmm. If as Tim mentioned, the big picture here is it's the percentage of the population that get vaccinated combined with the efficacy of the vaccination. And so if we have a highly efficacious vaccine that stays in the 90% or greater range for benefit, meaning 90% reduction in disease for those that get the vaccine, and we get 70 or 80% of the population vaccinated, we should be okay. If we have a less effective vaccine and less people get the vaccine because less are willing to, or we don't have enough, or you name the reason, then we don't get the same degree of benefit, and it's likely that we will have ongoing levels, maybe lower baselines, but ongoing levels of infection. And so the real answer there is time will tell, but it will be at least 70%. It may be more. And that's a really good reason to reinforce that this is, to the best of our knowledge at this point, safe, and it is important for everyone when available to get the vaccine.
All right, last community question. I am 9 weeks post-COVID-19, and I continue to have shortness of breath, chest pain, and palpitations. Is there any hope for a full recovery for me? And how should I handle the anxiety of not knowing long-term outcomes?
Dana, you can start.
That's a real good question. We know that people can have symptoms, even people who never had to go to the hospital but had COVID-19, they can have symptoms that last for weeks or months. We don't know how long, and it varies from person to person. There is a lot of variability, though, in there, whether it's loss of taste or smell that is gone for a couple weeks and comes back, whether it's some shortness of breath when you're walking upstairs, or maybe you just can't walk or run like you used to. Maybe it's just fatigue or this brain fog type of symptom. We don't really know. We know that there is a lot of supportive care involved in that, as far as things that you can do, if you need to take the Tylenol, the medication. But as far as anxiety as well, COVID, we have seen, hits many different organ systems and hits many different people in many different ways. That is one reason why, we are starting and will be ramping up our ability to do a post-COVID recovery clinic, and that's led by Keith Sale here at the health system, as well as Leslie Spikes with pulmonary and Brandon Comfort with internal medicine. We are going to have a multidisciplinary clinic to help address some of those things. Most important, it's going to be primary care or internal medicine, your primary doctor. Lung function is another big issue which we know can last, so having pulmonology on board. And you talked about anxiety. Certainly psychiatry and psychology are going to be on board to help, because just as COVID can affect different systems, the recovery is probably going to be multi-system as well. So we don't know. We don't have good answers for that, how long it will last, how long those symptoms will last. But certainly, we as medical providers and care providers are trying to create an outlet for you to be able to get the help you need. But and again, it starts, I think, with those main 3 or 4 specialties.
All right.
Well, Monday, we will get some expert advice on how to have crucial conversations around COVID-19, mask wearing, vaccinations, other difficult conversations. Our experts joining us are from KU in Lawrence. Professor Donna Ginther will offer a bit of perspective on research in these spaces, while communications professor, and nationally ranked debater Brett Bricker coaches us on how to talk to those who refuse science over personal or political convictions. As we wind up today, 2 special photos to share from Antonio and from Tommy Ralph, who watch the morning media update after school with their Christmas elf named Cannoli. These photos demonstrate what they've learned and are now sharing with their friends about quarantining and the pillars of infection prevention and control. If these boys can learn it and practice it, so can we all. Great job there, Antonio and Tommy Ralph.
Yay, cannoli.
Well, Tim, final thoughts?
Yeah, there's hope. This is a great time, but we can't let our guard down, and we have some really hard days ahead, and so can't let our guard down, and so hopeful, but we have to be very careful with what we do. And
Yeah, I think continue to have optimism, but continue to be vigilant. Masking, distancing, not meeting in large gatherings. We are coming up so close, and we are in the holiday season for many people. Continue to be safe so that we can spend the next holiday season together and not have unnecessary losses.
And as we wrap up, I wanted to share something today written by one of our own physicians, and it's associated with the picture that we'll share here on the screen. So I'm going to read it so I don't mess it up. One of my favorite patients ever died of COVID-19 today. Not at KU. He died in another hospital, away from his care team, largely alone, unable to breathe. Basically, he died feeling like he was drowning. He was chronically ill with a predisposing condition. He was vulnerable. Every time he came to clinic, he would cut me short whenever I tried talking to him about his conditions or our plans for his therapies. He lived 5 years with terrible chronic disease, and we kept him out of the hospital using cutting-edge technology. He benefited from the best therapies available. He was only supposed to live a few years when I met him. And the last time I saw him, I confidently told him he had another 5 years at least as it relates to his chronic diseases. When he came, he would only want to talk to me about my family. He demanded to see pictures of my kids at every stage. He knew my kids by name. He was so proud of them, almost like he was their grandpa. He especially warmed to the pictures of my youngest. He adored his wife. She adored him. They were always together. He made my world brighter. When I saw him on my schedule, the entire day was filled with anticipation of getting to hear his updates and give him mine. He became more than a patient to me. He truly was family. I am crushed and very sad. People, I beg you, this virus is real. It's killing all types of people, and we are losing some of the best of us with this costly pandemic that steals life from those who brighten the world around them. And I will say this about your front line, which is actually just the last line. We are so tired. Everything about this sort of rings true today. No doubt we spent time talking about vaccines and the hope they offer, and that is true. But nearly 3,000 people died across the country yesterday. Each of them had friends and family and communities that cared for them and about them. The vaccines that we talk so much about today are coming, and they will aid us in our response, but it will be months before they even provide benefit to the most vulnerable. If you are unwilling to stay home or unable to wear a mask when you absolutely must go out, please think about this man, his family, and his healthcare team who invested so much of themselves in his care. For many of us, the combination of preparation and extraordinary effort has lasted 10 months now. 10 months of 24/7, always on effort. We are tired, and we absolutely need everyone's help. That message, as we end today and think about what happens in the coming weeks, becomes very important. We do need your help, everyone's help. The rules of infection prevention and control that we have been sharing with you and their importance do not diminish over the next few weeks, probably not over the next few months. And it remains something that is in each of our power to change the story over the next few months. So with that, have a great weekend. Please be safe. We'll see you next week.